Welcome. This video will be the audible and visual representation of the scientific article written by Charona Heylen, Siel, Lareu and Reynaert to obtain the title of Osteopath, DO at the International Academy of Osteopathy. They conducted a study researching the effect of standardized osteopathic treatment of the upper thoracic region with the adjacent ribs on spirometric parameters and posture in adults with chronic respiratory diseases compared to asymptomatic adults and the control group. In this study, subjects suffering from chronic respiratory diseases were examined. Globally, the prevalence of chronic respiratory diseases is increasing because of the aging population and augmenting prevalence of risk factors. In Belgium, it is even the third most frequent chronic condition. Chronic respiratory diseases are classified into obstructive and restrictive chronic respiratory diseases. Asthma and COPD are the most common forms of chronic respiratory diseases, and both are categorized as obstructive. Restrictive chronic respiratory diseases have various causes and thus have a wider subdivision. In literature, the effect of manual therapy and osteopathic manual treatment on obstructive chronic respiratory diseases had negative results or provided inconclusive evidence for their effectiveness. It is suggested that restrictive chronic respiratory diseases are more indicated for osteopathic manual treatment. But since only one patient with a restrictive chronic respiratory disease participated, the results of this study will only include data of subjects with obstructive chronic respiratory diseases. The numerous studies on osteopathic manual treatment and obstructive chronic respiratory diseases arose in search of cost-effective, non-invasive forms of treatment, as asthma and COPD account for more than 10% of the annual care expenses in Belgium. The standardized osteopathic manual treatment protocol for this study was devised to improve the overall thoracic mobility via mobilization of the upper thoracic vertebra and adjacent ribs, to restore its mechanical, vascular, and neurological function. The objective of the study was to evaluate the effect of standardized osteopathic manual treatment of the upper thoracic region on pulmonary function and posture in healthy subjects and in subjects suffering of chronic respiratory diseases, in order to determine the role of osteopathic manual treatment as a complementary form of rehabilitation. This study was a randomized, controlled, single-blinded trial. It was conducted at the International Academy of Osteopathy. The study had a sample size of 44 subjects, of which 30 females and 14 males. The mean age was 33.93 years old, with a standard deviation of 14.23 years. Subjects were divided into two groups, asymptomatic and symptomatic. These two groups were subdivided into an experimental group and a control group. 1/3 of the total sample size received sham therapy. The symptomatic and asymptomatic participants were listed in order of their test appointment. Each third patient listed in both groups was placed in the control group in order to have an equal amount of asymptomatic and symptomatic subjects in the control group. Exclusion criteria were defined for symptomatic subjects: Deers thoracic 4D scanner, spirometry, and osteopathic manual treatment. The exclusion criteria were discussed in the informed consent and covered in the questionnaire. The questionnaire was devised to exclude all subjects that could experience harm by this study, as it assesses the medical condition of the symptomatic and asymptomatic patient. Accordingly, This study ensured the safety of all the participants. The measurements were performed by a group of 3 students. They conducted the following research procedure. Researcher 1 made sure that the subjects read, filled in, and signed the informed consent and questionnaire. Thereafter, the subjects undressed themselves up until their undergarments. Their height and weight were measured, followed by a spirometry test guided by researcher 1 and a Deers scan guided by researcher 2. After the measurements were taken, researcher 3 performed the intervention on the participants. Subjects belonging to the experimental group were given a standardized osteopathic manual treatment of the upper thoracic region T1 till T5 and ribs 1 till 5. Subjects belonging to the control group were given a standardized sham therapy. The subjects were unaware of which intervention they were receiving. After the intervention, a second spirometry test and Deers scan were performed. The Deers Formetric 4D scanner is an installation used to measure posture. Participants were asked to stand in a relaxed, upright position in front of a computer. A raster of lines was projected using light on the participant's back. The curves in which the lines were projected on the volunteer's body were converted by calculations to form a 3D image on the computer. 1 test scan and 3 definite scans were conducted every time posture was evaluated. The average result was used in the study. Lung function was measured by means of the Spirobank 2 Smart Spirometer. The spirometry testing results were processed via WinSpiro Pro PC software. The spirometry results were interpreted according to the ERS ATS guidelines. A forced vital capacity maneuver was performed according to the ERS guidelines. 3 sufficient FVC maneuvers were needed before and after the intervention. Each time, the best out of 3 maneuvers was selected. The osteopathic manual treatment was standardized in execution and duration. The standardized OMT protocol for the upper thoracic vertebra and adjacent ribs were based on the e-book concerning the thoracic spine. The treatment of the upper thoracic vertebra consisted of a flexion, extension, and a rotation left and right mobilization in the sitting position and a lateral flexion left and a lateral flexion right mobilization in a side-lying position. The treatment of the adjacent ribs consisted of an expiration and inspiration mobilization of the left and right upper 5 ribs in a prone position. Each technique was performed for 30 seconds, making the total duration of the first intervention 5 minutes. The researcher made sure an equal pressure was applied to all 5 ribs or vertebrae. Sham therapy for OMT is not easy to apply. A sham protocol was assessed based on previous studies concerning OMT. The thoracic vertebrae T1 till T5, as well as the sternum, upper dorsal and ventral ribs on the left and right side, were consecutively contacted by the researcher. This contact did not induce any mechanical changes or neurological changes, as it lasted no longer than 30 seconds. In order for the sham therapy and OMT to have an equal duration, the subject was consecutively in a sitting, supine, prone, and side-lying position. The patient was encouraged to breathe normally throughout the therapy. All data collected by the Deers software package and the WinSpiro Pro software package was converted into a Microsoft Office Excel file. The collected data were analyzed by the MetCalc program. For the Deers measurements, 4 parameters were chosen out of all measured parameters which evaluated the thoracic kyphosis. For the spirometry measurements, 4 parameters were chosen. In this table we calculated the mean length, weight and age with standard deviation per group. For spirometry, we compared each parameter before and after the intervention within each group. A paired sample t-test or Wilcoxon test was used to calculate the p-value. Within the asymptomatic control group, PEF value showed statistical significance. Secondly, we compared the pre-intervention and post-intervention data between group 1 and 2 and between group 3 and 4, using a student t-test or a Mann-Whitney U-test. For both groups, no significance was found. The Deers parameters were evaluated using the same method as the spirometry results. Comparison of each parameter pre- and post-intervention within each group showed statistical significance within group 2 for 3 out of 4 parameters. Comparison between pre-intervention and post-intervention data between the asymptomatic groups 1 and 2 and between the symptomatic groups 3 and 4 showed no significant improvement of the Deers parameters. Only in group 2 there was a statistical significance for spirometry and Deers parameters. This unlikely occurrence remains unexplained. So, we verified for each parameter if there was a positive or negative tendency. This qualitative study shows a general improvement in active treatment groups. Since the results have no statistical significance, the hypothesis must be rejected even though the qualitative study shows a general improvement in active treatment groups. If we take a better look at the characteristics of the population, we see that the participants were predominantly female. The mean age was 33.93 years old, with a standard deviation of approximately 14.23 years. The underlying cause is the presence of 2 age clusters in the subject group, as you can see in this graph. The age clusters were related to the presence of symptomatic older subjects and the asymptomatic younger subjects. As the premised randomization was not successful, the results cannot be generalized to the Belgian population. As the study only tested Caucasian participants, results also cannot be generalized to other ethnic groups. This study experiences several limitations that can be the underlying cause of the overall negative results. In contrast with the previous statement of a double-blinded design in the protocol, it was only possible to obtain a single-blinded study. Due to organizational measures, randomization was also limited to a 3:1 ratio. The strength of the study, however, is that it uses multiple parameters to evaluate lung function and posture. A study conducted by Guinea and Chu showed significant results of OMT on pediatric subjects with asthma. However, this study only used PEF to evaluate pulmonary function. ERS guidelines suggest that multiple parameters need to be evaluated to study pulmonary function integrally, especially evaluating subjects suffering from restrictive CRD. It is suggested to continue using multiple parameters in future studies to obtain a conclusive evaluation of pulmonary function. Furthermore, other studies recommend healthcare professionals to conduct pulmonary function measurements. In this research, measurements were obtained by students. Additionally, the spirometry procedure was unfamiliar to most participants and showed to be a complicated process. This indicates that optimal conditions were not obtained during spirometry testing, despite all efforts to make the process easy to comprehend. In comparison to other studies focusing on posture and lung function, the interventional protocol showed the similarities in composition and treated anatomical regions. In this study, intervention protocol was said to be a standardized OMT. Treatment was an in advance defined sequence of techniques. Other studies, in which standardized OMT was used, showed negative results. Studies using patient need intervention showed significant results. The objective of this study was to improve posture as hyperkyphosis. It is a common postural dysfunction that can be observed in patients suffering from asthma. It is unlikely that a single intervention protocol that was used in this study could cause significant enhancement in thoracic kyphosis. With only one treatment session, no improvement was seen. Studies aiming to improve hyperkyphosis used mobilizations and stretch exercises over longer periods of time. Results of these studies showed a positive effect on posture. In this study, treatment of anatomical structures in one local area, upper thoracic vertebrae and adjacent ribs, was premised. Previous studies concerning OMT and pulmonary function incorporated different anatomical regions such as the diaphragm, thoracolumbar junction, and suboccipital region. Treatment of additional regions could have affected the outcome of the study. The mechanical aim of the OMT in this study was to improve the general mobility of the upper thoracic region, as it directly influences chest and pulmonary functions. Other studies focusing on pulmonary function improvement use techniques on the upper cervical vertebrae, first rib, thoracic inlet, the diaphragm, and techniques to improve lymphatic drainage. It is suggested that OMT consists of techniques to improve diaphragm function and lymphatic drainage in order to have an effect on asthmatic subjects. The sympathetic nerve supply of the vascularization of the respiratory system is situated in the upper thoracic region, T1 till T5, the focal point of treatment in this study. This study aimed to improve vascularization and thus function of the respiratory system by influencing these segments through OMT. OMT of these regions aims to lower the sympathetic output to the effectors. Previous studies support a parasympathetic response after OMT. The intervention protocol of Henley et al. Consisted of a single myofascial technique on the upper cervical spine. The intervention protocol in the study conducted by Ruffini et al. Was patient needs based and limited to craniosacral techniques. Another study discovered no significant changes in sympathetic output in their study concerning spinal manipulation of the upper thoracic vertebrae. Moreover, it has to be noted that the sympathetic nerve supply to lung parenchyma itself is scarce. Hence, OMT of the upper thoracic segments should be reconsidered if the aim is to neurologically improve pulmonary function. Especially treating asthmatic patients, this reconsideration is recommended, as the parasympathetic dysfunction is more prominent than a sympathetic dysfunction in the pathology. This study does not support the statement that OMT is a complementary form of rehabilitation in CRD, nor does this study confirm that OMT has an influence on posture.